everyone to Geriatric Medicine Grand Rounds. I'm so glad you can all join us on this Friday in November. It's November now. Believe it or not, that's what you're supposed to say in November. I can't believe it's November. But welcome everyone. We have a really fantastic speaker today, Dr. Jim Leverenz, who is likely familiar to many of you. He is based now over at the Seattle VA as a professor of neurology, has tremendous expertise, particularly in Lewy body dementia. He was at UW and the Seattle VA for many years, and in 2014 he headed over to Cleveland, and there he directed their Center for Brain Health and their Alzheimer's Disease Research Center. And his particular area of focus and expertise is Lewy body dementia, as well as some atypical Alzheimer's disease, and he has a lot of expertise. I had the privilege of learning from him when I was a resident and a fellow, rotating over at the VA, and learned so much and have carried that forward. So I'm looking forward to hearing your talk, and thank you for taking the time to do this.
Sure, thanks. Can all hear me well? We'll get started. I kept trying to trim my slides down, so we'll see how that works. So thanks everybody, and look forward to seeing some of you in clinic over here at some point. Today I'm just talking about Lewy body dementias, which is a plural term, and my disclosure is just funding for the various research that we do, particularly around Lewy body disorders. Overview-wise, I want to talk about definitions because I think it's really important. This is an area where it's really important to understand what you're talking about, particularly as it relates to clinical syndrome versus disease, which you're starting to see in other neurodegenerative disorders such as Alzheimer's disease. The Lewy body dementias, what we talk about mild cognitive impairment dementia, and then somewhat what's new, which I think is really kind of fitting in with what's happening in Alzheimer's, which are assays that we have available that can give us very specific diagnostics, and then sort of the controversies around biologic definition versus clinical definitions. So I'm guessing most of you are familiar, but just to go over it, dementia generally in my mind usually means that they have a change, usually cognitive behavioral, that impacts their ability to do some day-to-day functions, and that it's a decline from a previous level. So I've done a little work in Down syndrome, so that's a little bit hard sometimes to define what dementia is there. As you probably know, they're at a high risk for Alzheimer's disease. Often in clinic, I'll just ask, often to get straight to the point, I'll just say, if you had to leave town unexpectedly to their caregiver, to their spouse, child, if you had to leave town for a couple of days, would they be okay on their own? And that kind of quickly gets them, oftentimes you get the, oh no, there's no way I would do that, or yeah, I had to leave a week ago, and he did just fine, or she just is fine. Mild cognitive impairment really means there has been a change in some sort of documented way, but that their ability to function on day-to-day level is relatively intact. And that could be a little bit tough because if you have an early onset dementia, somebody might not be able to manage their job. Let's say they're a physician. You probably don't want somebody with MCI treating patients, but probably on a day-to-day basis, they could manage their own affairs. And again, it's a decline, but sort of maintaining that, it's that ability of function to differentiate MCI versus dementia. The other thing I really like to emphasize, and I do this a lot with patients as well, because they get confused, is that syndrome doesn't equal disease. I usually use the headache. I say, you got a headache, could be stress, could be a migraine, could be a brain tumor, could be a bleed, all sorts of different etiologies. It's a syndrome, doesn't mean that you understand what's going on underneath. And I think brain disease is the same. And of course, as we've gone along now, we realize brain disease is often quite complicated, particularly in the elderly with multiple underlying etiologies. But anyway, syndrome doesn't equal disease. So I'll talk to people about what I think their syndrome is. And then I'll say, we're going to do some biomarkers or other kind of evaluation to figure out what the disease is if we can. Parkinson's disease, classic definition, right? Arresting tremor, increased tone, slow movement, postural instability. If you've been in my clinic, you see me do the famous pull test. Always brace yourself in case they start to go over, and you might go over with them too. Pathologically, classically, what we see in the brain of people with Parkinson's is degeneration, particularly of the neurons in the substantia nigra that contain dopamine. And within those neurons, we see the so-called Lewy body inclusions. And we ultimately, as we've gotten better at identifying those with immunohistochemistry and so forth, we see they're not only in the substantia nigra, but the locus coeruleus, other areas of the brainstem, basal forebrain, and even in the cortex and sort of neocortical disease. And can you guys see my arrow here? Okay, just making sure. So here's a normal substantia nigra here in the midbrain, and here's somebody with Parkinson's, and they've had a neurodegeneration there and loss of neurons. If you go a little bit further in and look at these neurons under the microscope, here's a nice substantia nigra neuron. You can tell because it has this neuromelanin in it. Here's the nucleus, nucleolus, cytoplasm as well, and then this nice circular structure, which is a Lewy body. So embed that in your mind. It sometimes appears in board questions and things like that. And what we now know is that these Lewy bodies are primarily made up of a protein called alpha-synuclein that we all have. It's a synaptic protein. If you stain for it in brain, it's all over the place. But we now know that mutations in the gene and certain kinds of rare forms of duplication, almost like a Down syndrome of alpha-synuclein, where you have 3 copies instead of 2, dramatically increase your risk for developing one of the Lewy body disorders. And all Lewy bodies have this alpha-synuclein protein in them, and they're aggregated together. Similar, and as this will be relevant to later discussion, similar to what you see in prion disease, where you have the prion protein aggregates together, the alpha-synuclein protein aggregates together, and presumably that causes some dysfunction of the cell and neuronal loss. It's really increased from a person who does some neuropathology and our ability to detect these not only in the brainstem, but classically, but also in other regions of the brain. So here's a slide from a couple of areas where you can see the sort of classic Lewy body staining, typically what you see is a staining around the periphery of the Lewy body. But now we can also see processes that contain the synuclein protein. And then actually interesting, you can see here's a neuron with multiple Lewy bodies in it. So it really improved our detection abilities. So we often call these Lewy body inclusions, and Lewy neurites are kind of typical ways that we describe them. But this is with this antibody to the alpha-synuclein that we can see this. I put 1.4 million Americans are thought to have one of the Lewy body dementias, which includes dementia with Lewy bodies, Parkinson's dementia, or what we might used to be called Lewy body variant of Alzheimer's, people with Alzheimer's that also have Lewy body changes. And the 1.4 million we came up with about, 15, 20 years ago is probably a low estimate now. It's kind of pretty frequent, actually, when you think about it, and that's why it's important to understand. One thing we know about clinical care, and it's no fault of anybody's really, is it's very difficult to make the diagnosis. You'll see when I talk about working with experts in the field, how we're wrong, even 10 to 20% of the time when we use the biomarkers for Lewy body disease. So it's a difficult one. People often get very frustrated. They have multiple visits. Sometimes they get the inappropriate antipsychotics because they're having hallucinations. It causes the patients and families a lot of distress because they don't know what's going on. For a more pure Lewy body disease as well, and I think I'll talk about this later, these patients often have a bit of insight, not like your typical Alzheimer patient who says, no, my memory's fine, and everybody behind them is shaking their head. No, this is often they know something's wrong. It can be very distressing. You do see depression, anxiety in these individuals. So it's just important to do your best to make a diagnosis. And then research-wise, again, until pretty recently, there hadn't been really good, consistent, coordinated research funding. And at the end of this, I'll talk about our Dementia with Lewy Body Consortium, which is a research study. So going back to sort of the general dementia, this is from the local study, the ACT study, looking at the pathological changes that we see in people who had a dementia diagnosis and came to autopsy. And what you can see here, I think, pretty easily is that, number one, there's lots of Lewy body disease identified, but often it's coexisting with multiple different pathologies. So Alzheimer's disease, Alzheimer's and vascular disease, hippocampal sclerosis, I'll talk about very briefly later. So pretty typical. And all the studies in the community-based autopsy studies now, the famous one in Rush, have all seen the same thing, that most people with dementia, the most common kind of dementia really is multi-etiologic dementia. So one of the things we're trying to figure out is how to use biomarkers to define exactly what's going on in somebody's brain when they come in with a dementia. And then how do we ultimately use that for disease-modifying therapies as we start to get into that arena. So the three dementias, Lewy body dementias I'm going to talk about is Parkinson's disease dementia, dementia with Lewy bodies, and then Lewy bodies that we see in Alzheimer's disease. So the clinical diagnosis of Parkinson's dementia is pretty straightforward, which is you have somebody who has established Parkinson's disease, classic, they've got a resting tremor, they've got rigidity, they're responsive to the dopamine therapies, and they've developed dementia in the context of that. And so it's pretty straightforward. So you're seeing somebody, they've had Parkinson's for a number of years, and now the family's starting to notice they're having some troubles with their thinking skills. They may have some of the other things that we think about with dementia with Lewy bodies, like hallucinations and so forth. Probably a pivotal study early on is Dag Arsland in Europe had a cohort in Europe of different of individuals with Parkinson's disease. And as they followed them over the years, you can see by about 10 to 15 years, almost 80% of the individuals with Parkinson's disease fulfilled criteria for dementia. So really, that was kind of an eye-opener for a lot of people. Of course, one question that came up was, is this due to coexistent Alzheimer's, or is actually Parkinson's, the Lewy body disease we see in Parkinson's, driving this? And I'll address that in a second here. Even early on, we often notice that people with Parkinson's will complain. They don't multitask as well. They get off track more easily. Kind of less the classic amnestic thing that we see with Alzheimer's disease. And more typically, again, people will say, I just have to be really careful not to get off track, and it's really hard for me to get back on track. Something kind of a little bit different and working memory-based, attention-based. And it's just a quote, Dog's paper, 2009, that cognitive impairment is a key feature of Parkinson's. We worked with a group at Penn and a number of other sites to look at about 140 cases of Parkinson's dementia that came to autopsy, because we wanted to understand what the pathology was. And what we really found was that when we looked at this, while there was a frequency of Alzheimer's of about 30%, the vast majority of these individuals did not have Alzheimer's disease. And the Lewy body pathology, particularly, cortical and limbic disease, was associated with the dementia. So there is this kind of idea that it's actually the Lewy body disease that's driving at least part of the dementia that we see in these individuals. Interestingly as well, though, there was this ApoE4 effect even when we control for the Alzheimer's pathology. So there's something going on with ApoE4 in terms of Lewy body, Parkinson's dementia, true for dementia with Lewy bodies. Just a few caveats on this end. When you look at other cohorts that have since come out, like the PPMI, Parkinson's Progression Marker Initiative, funded by the Michael J. Fox Foundation, they've seen a little bit lower frequency of dementia over time. Again, at 20 years, about 3/4 of individuals have filled criteria. Similar risk factors to what Arsland studies found. It is important to recognize the PPMI cohort is kind of similar to a lot of cohorts, very Caucasian, very highly educated. I think the average Average, education there is 4 years of college, lots of lots of masters and PhDs and MDs and so forth. It's a very motivated group, so they tend to be very well cared for in terms of co-pathologies. The next group I want to talk about is dementia with Lewy bodies. So there are criteria for dementia with Lewy bodies. The main feature that we look for that differentiates it between Parkinson's dementia, dementia with Lewy bodies is the so-called 1-year rule. That always irritates people, but that's the rule we kind of use to clinically, right, syndromically, to divide people into Parkinson's dementia versus dementia with Lewy body. Obviously, they need that dementia. They should have 2 or 1 possible and 1 indicative biomarker for the key core features that are fluctuations, visual hallucinations, features of Parkinsonism, although typically it's less the tremor predominant and more the rigidity, slowness of movement, and REM sleep behavior disorder. We know those individuals often have Lewy body pathologies and underlying underlying pathology. There are indicative biomarkers, so you can say somebody has probable DLB if they have one of the core features in addition to dementia, and they have a positive biomarker. And what I haven't added here, because this is from 2017, is the synuclein aggregate assay, the SAA, that I'll talk about later. But DAP scan is something we often use. MIBG that we don't use a lot because it's something input into the cart, or a PSG confirmed REM sleep behavior disorder. So I can't emphasize enough that if you want to be accurate about diagnosis, that you really need to do an in-house sleep study. At-home sleep studies really don't differentiate other kinds of movement disorders at night from REM sleep disorder. They have to be in REM sleep and then have the physical activity that you typically shouldn't have. So I'll go through some of these symptoms. I sort of alluded to this. PDD and DLB have very similar symptoms. It's all really about timing, yes. There is a big argument, there continues to be a big argument, are they just variants of the same disease? I think I always like to say there's a biology behind why somebody goes for 10 or 15 years with Parkinson's and doesn't develop dementia versus somebody who presents with dementia and later develops Parkinsonism, and that's part of what we try to understand. But this continues to be a debate. And then Lewy bodies in Alzheimer's disease is very common. So another big group. I always like to show this historical picture. So here's Alois Alzheimer that described Alzheimer's disease. These beautiful pictures in the background. And this is Friedrich Lewy, who was rotated through his lab, so to speak, a long time ago. So we actually see that Lewy body pathology is very common in Alzheimer's disease. And using the alpha-synuclein immunohistochemistry that I talked about earlier, making sure we look at the amygdala, because that's an area where we see early pathology, or in the olfactory bulb, that even in mutation types of Alzheimer's we see frequently, so it's not an age-related phenomenon. These people are in their 40s and 50s. We see in Down syndrome where there's a frequent Alzheimer's, and sporadic AD, et cetera. So this is something that's been really well documented. When we look at the Lewy body dementias overall, one of the things that we notice, I sort of alluded to, is we tend to see less of the classic amnestic, unless it's somebody with coexistent Alzheimer's disease, more executive. These patients tend to have better insight. They have a lot of visual spatial dysfunction. We know that visual cortex can be involved very early on. Sort of classic apathy. A little more depression, I think, probably because to be depressed, you have to have insight, and these patients often have more insight than your typical Alzheimer patient. You may have an irritability issue with the Alzheimer patients, but in a more pure Lewy body disorder, you tend to see some insight. And of course, we see the psychotic symptoms, particularly the hallucinations. So I always like to show this one because this was the weirdest hallucination anybody's ever told me. This guy said, I see squirrels driving tractors in my backyard, which is quite remarkable. And his wife says, there are a lot of squirrels out there, but they're not driving tractors. Usually it's an animate object that people see, not an inanimate like a tractor, but I have to always throw this in. Um, One thing I would say that it's very common for people to think a patient's having hallucinations when they're having actually delusions. And that's important because false beliefs are really common in Alzheimer's disease. You know, my patients will say they're in their 80s and they say, "Oh, my mother visited yesterday," you know, and the family will interpret that as if they saw them yesterday, but it's just a false belief. It's not that they actually saw their mother who's been dead for 20 years. Um, and so that's important. So I'm usually asking them, were you in the room? Did they actually see something? And a more typical thing people see is like a dog or cat or people. I had a patient just a couple weeks ago now, or maybe just last week, that said he saw dead people, which alluded to the movie, and I thought, okay, maybe this is delusional. And I said, how do you know they're dead? And he goes, well, I go over, and when I reach over to them, they disappear. Uh, and and it's usually not somebody that they know. So he says, no, I don't know who they are. And the weirdest thing is it often doesn't bother them. So it's not uncommon to ask if patients see things, and they'll say, yeah, I always see a little dog in the corner. I know we don't own one. It doesn't really bother me. And the spouse will look over and say, you never told me this. And he goes, well, it didn't really bother me. So people will often have to ask the question and make that sort of hallucination versus delusion differential. I alluded to the REM sleep behavior disorder, strongly associated with Lewy body pathology. Usually I just ask people, do they act their dreams out at night? And it's got to be the bed partner. And a lot of times the bed partner will say, well, I had one patient caregiver say, well, he used to wake me up, or she said, no, he doesn't act out his dreams or wake me up acting out his dreams because I had to move to another bedroom because he used to wake me up acting out his dreams. And I often start with melatonin to try to treat that. Certainly go up to like 20 milligrams at bedtime, about an hour before. Often can suppress that a little bit. People can hurt themselves. They can fall out of bed, things like that. I've had patients injure themselves. Um, the Again, I mentioned at the end there of this slide, it really requires to really define it. If you want it, it needs to be an in-house polysomnography to really have that EMG at the same time and see that they're having excessive motor activity during dream sleep. You also have to be very careful because I've seen this also in sleep reports that the sleep report will say the patient didn't have REM sleep disorder, but then you look at the sleep study and they never had REM sleep. So you can't have REM sleep disorder, movement disorder, if you've never had REM sleep. So it's always good to double check on that. And there are lots of other sleep disturbances that involve movement, and so the families can often struggle with differentiating those. And of course, like everything else in aging, it's frequently more than one disorder that's going on. But that is strongly linked to Lewy body pathology and can often happen 10 years ahead of before any other symptoms kick in. There's a famous study called NAPS now that if you wanted to look it up, that's following these patients prospectively, sort of as a high-risk group. So what do I do when I'm seeing these patients? I do the typical stuff that we all do in terms of blood work, in terms of cerebrospinal fluid, or blood tests now. I look for A beta, tau, p-tau. I'll talk about momentarily, synuclein aggregate assay that works very well in spinal fluid. We have autopsy confirmation. This is highly predictive of finding Lewy body pathology at autopsy. Imaging will often tell us something about the areas of the brain that aren't working right. But we know, for example, the DAT scan can be abnormal, dopamine transporter scan can be abnormal, and PSP, certain kinds of cortical basal degeneration. It's not specific to Lewy body diseases, Parkinson's, dementia with Lewy bodies. PSP is something common. FDG PET can tell you tend to see this visual cortical hypoperfusion and FDG PET. Again, not specific to Lewy body disease, but something that can be indicative. And I talked about the MIBG cardiac imaging. And I always like to get some sort of structural imaging. A lot of times these patients, if they're more of a pure Lewy body disease, they don't have a lot of MRI, they don't have a lot of atrophy. So when I see somebody with a, MoCA that's in the teens, and I look at their scan and they really have very little atrophy, makes me think about a Lewy body disorder. This is a DAT scan, and you can see kind of a normal here, and you can see the, actually I probably have to do here, you can see Alzheimer's disease without any kind of dopamine deficiency. And this is somebody with dementia with Lewy bodies, but could easily be somebody with Parkinson's disease or progressive supranuclear palsy. Again, on FDG PET, you sometimes see this hypoperfusion in the posterior cortex here. So sort of indicative, not diagnostic. And I wouldn't pretend to be MIGB interpreter. This is something you could take to your nuclear medicine doc. But this is where you see this sort of denervation of the heart. Probably the biggest thing that's happened in the last couple of years in this area has been the realization that the synuclein aggregates that we see in these Lewy bodies neurites are actually released into the spinal fluid. And that, in fact, if you measure them with a test that's very similar to the prion test, so instead of looking for prion protein aggregates, you look for synuclein aggregates, that it's highly predictive of somebody having Lewy body pathology, whether or not they have other changes going on in the brain. And this just really changed the field quite a bit. It's really a diagnostic test for Lewy body disease. There is a commercially available form called Syntap, group called Amprion. And just again, my disclosure, they don't pay me any money, but they do have supplied us with research CSF testing as part of our study, the dementia with Lewy body study I'll talk about in a minute. This has led to several groups thinking about using these biomarkers. How do they define disease? And I think you've seen two major sort of groups. There's the group out of Michael J. Fox Foundation that's talked about here at the bottom, this sort of biological definition, and they're including everything under the umbrella of Lewy body disease. So they talk about people having like REM sleep disorder, but having the synuclein change, then having the DAT scan abnormality, so they'll have a positive SAA test at this point in the spinal fluid, then they'll have the DAT scan abnormality, then develop a clinical syndrome. And they think of DLB, PD all under the same umbrella. The movement disorder group has something called synergy here. You can see this term here. That is a little bit looser in its definition of these diseases and say it's really important to recognize the clinical syndrome, which I think is important from a management point of view. I think that the group from Michael J. Fox, I think the focus really is as we develop disease-modifying therapies, it's going to be important to recognize, do these people actually have a synuclein pathology going on? If we're going to give them a synuclein antibody, for example, to try to get rid of their synuclein proteins, aggregate proteins. And just comparing them again, there's a little bit of debate here. Again, the synergy out of the movement disorder group's a little more focused on the clinical aspects, and the neuronal synuclein disease talks about the pathology happening. You see this in the Alzheimer's field as well, right? That we have people who have now blood-based tests that are positive, or brain imaging, amyloid imaging that's positive, and are actually cognitively normal. And similar to this, the one area that we really need to do some work in is understanding what is it that drives progression. So if I have somebody with Alzheimer's, they have a positive Alzheimer's blood test, I can't tell them, are you going to move into mild cognitive impairment next year or in 10 years? I really don't know. And it's similar in here. We don't have good markers for progression. It's something we're working on. We have certainly lots of ideas about that, but this is a big area in the neurodegenerative field that we have these diagnostic tools now for knowing what the pathology is, mostly. But but we don't have good tools yet for telling us who's likely to progress and who likely isn't. So this kind of overview of what we've talked about so far. DLB is tough, the Lewy body dementias, because of the clinical, pathologic, genetic heterogeneity. We do need clinical trials, personalized therapies particularly, and we need these progression markers. Lots of opportunities, prodromal disease now. We can look at these REM sleep disorder patients and look at what are the things that project somebody who has REM sleep disorder and gets Parkinson's or dementia Lewy bodies in a couple of years versus 10 years. We have these emerging biomarkers. So I thought, because the clinical group, we talked about a little bit about treatment and there are a number of treatments that we have that you can do for cognition, for behavior, for sleep. Mood is an important one. What we know is that rivastigmine can be really helpful in terms of cognition. It doesn't treat the disease, but it treats the symptoms. So it's something we use both in Alzheimer's disease as well as Lewy body dementia, whether it be PDD or DLB or somebody with Alzheimer's who developed more Lewy body pathology. So we do like to get them on some sort of dopamine deficiency drug. There's just a number of different trials that have shown the cholinesterase inhibitors also seem to have some effect on the psychotic symptoms that we see in these individuals. So there's a little bit of benefit of immediate memory, working memory that you use while you're having a conversation, something Lewy body patients really struggle with. But we also see a reduction in the psychotic symptoms when they're on it. And oftentimes that means we don't have you using an antipsychotic in these individuals, which is really quite useful. And for many patients, it's not really bothering them very much. Other benefits of a cholinergic therapy is there does seem to be a reduction in fall frequency. And I think that's probably attention-based. And it does seem to, again, lower the hallucination frequency in these individuals. So oftentimes my first treatment, if it's not really problematic, they're not having a lot of behavioral disturbances, will be to treat them with a cholinesterase inhibitor as an initial trial so that I don't have to use an antipsychotic, for example. I'm going to go back to this for just a second. If I do have a psychosis, if I have somebody where they are I've got them on a cholinesterase inhibitor and they're still having a lot of behavioral disturbances because of psychosis, then I will use things like some of the atypical antipsychotics. I particularly like quetiapine because I can use it in various doses. And it's amazing how low dose some of these patients can respond to in terms of quetiapine. I tend to obviously avoid the drugs that have strong dopaminergic effects in terms of Parkinsonism and things like that. So it is something that I do use, but I really try to go with cholinergic therapy first. In terms of amyloid therapy, we do see that oftentimes people do have coexistent Alzheimer's disease. We do have biomarkers for looking at that. And so there is a lot of interest in using ultimately amyloid therapy in a certain subgroup of patients. We know that a certain number of people with Alzheimer's have coexistent Lewy body disease. So it is something that we'll be very interested in looking at. So we're doing okay on time, I think. I'm looking for my clock. There it is. So I'm going to talk briefly about our research program. I'd like to talk a little bit about research, and particularly about Dementia with Lewy Body Consortium. It's a multi-site consortium across the U.S. So this is a study. It's a UO1 grant with NINDS. So it is really a collaboration between the NIH when they're open for business and clinical sites like ours. This is 8 sites across the country right now. We've had a couple of sites that have come and gone. And basically what we're doing, kind of like an Alzheimer's center, we're following individuals over time. who have either mild cognitive impairment or dementia that we think is due to Lewy body disease, either dementia with Lewy bodies, Parkinson's dementia, or Alzheimer's with Lewy body dementia features, clinical features. And this has been going on now for almost 10 years. The study looks at people at baseline. We do imaging, particularly MRI, as well as dopamine transporter scans. We do a lumbar puncture and do the measurements for the alpha-synuclein protein that I discussed earlier. We do cognitive biofluid collection for research and brain donation. I mention this because if any of you are itching to do research, we have lots of resources. We have well over 200 patients that have been enrolled in this study, and we have a number who've come to autopsy, so we have confirmation about whether they had Lewy body disease or not. This is from the beginning of this year, what the numbers look like. We're up to about 240 individuals who've enrolled in the study so far. You can see that when they're enrolled, that they are, their UPDRS part 3 is about 27, which is pretty high. So they're very Parkinsonian. But again, as I mentioned, they tend to have less tremor predominant. They tend to be more symmetric. So particularly in the older patients, some people, it's been difficult for the family will say, well, I thought that was just normal aging, but we'll see this patient, they're stooped over, they're shuffling, but they may not have the classic resting tremor. MoCA-wise, they're sort of a 20, so they're sort of in that transition between mild cognitive impairment to early dementia at the time that we see them. One of the things that's been really quite remarkable, and is actually, if you look at the literature carefully, has been seen by a lot of people, is that for dementia with Lewy bodies, so people who start with a dementia syndrome, then later, either simultaneously or later develop Parkinsonism, that's male predominant, quite dramatically so. And this has been confirmed at autopsy as well. We don't understand completely why that is. In Parkinson's disease, there's a slight male predominance. You can make comments about men versus women in terms of cognition, et cetera, and delusions and hallucinations, but there does seem to be this biological male predominance that we don't fully understand. When we look at the clinical features of our cohort, and this is a little bit older data, but what you can see is we see fluctuations, hallucinations, as you might expect, partly because they can't enroll in this. They fulfill criteria for possible or probable dementia with Lewy bodies. One thing I like to mention is that these individuals, their data goes into multiple databases. So there's what will now be a VA, University of Washington database, but the NAC database for Alzheimer's disease and the Parkinson's biomarker program database are available for people who want to do research in this area. So our data goes into that. This is considered a collaborative project with the NIH. Just a few things of studies that we've done. This is looking at the biomarkers of Alzheimer's disease in this cohort, looking at spinal fluid biomarkers. And what you could see is that there was a nice correlation. You'd have to maybe pull the paper up if you wanted to look at that. But when we looked at the autopsy, it fit very well. What we noticed is the Alzheimer markers kind of float around in people who don't have a full Alzheimer pathology going on. But what we now know is that once the Alzheimer's really kicks in, it kind of stays there. The biomarkers stay there. And that's when we also start to see that the amyloid imaging starts to turn positive as well. These individuals die pretty quickly. And so we've had 65 deaths so far. Actually, we've had 85 deaths. We have 65 deaths that we've pulled to autopsy. And we have looked at the first 43 cases. And unlike Alzheimer's, where people can kind of enroll in these studies and it may be 5-10 years before they come to autopsy, these individuals have a fairly short lifespan from the time of diagnosis. And so actually we have a less than 2-year time frame between last biomarker clinical evaluation for the study and autopsy. So we think that the findings we see at autopsy fit nicely with what we're seeing in the spinal fluid and other markers that we're using. What we found, and I kind of alluded to this earlier, is that in individuals who've come to autopsy, that most, 34 of these 44 cases, had neocortical or limbic Lewy body disease. So either in the neocortex as well as the limbic and brainstem or limbic system. There were 3 cases that had what we call amygdala predominant, where it was predominantly in the amygdala. All of those cases had coexistent high levels of Alzheimer's. We know in Alzheimer's disease, the amygdala tends to be a site where we see Lewy bodies. And we want one brainstem only case that kind of came to us as a REM sleep disorder patient. And then we have 5 negative cases, people that we thought had dementia with Lewy bodies fit the criteria, but at autopsy did not have Lewy bodies no matter how hard I looked. And they had the one thing that was surprising is they had quite a variety of different pathologies underlying their dementia. I thought it would be mostly Alzheimer's or mostly something else, but it was really quite a variety of different things, including somebody with progressive supranuclear palsy, where I know that the neurologist that evaluated him said he swears he did not have any eye movement abnormalities. We know there's a subgroup of patients like that. This is important, again, in terms of thinking about the spinal fluid test, the SAA test, because we don't want to give a PSP patient a synuclein drug. Not only do we not want to give it to them, but if we're doing a clinical trial, we don't want those people in the trial because it'll diffuse the results. This is just some of the pathology that we saw. Again, kind of intermediate Alzheimer changes for most of the neocortical and limbic cases. The amygdala predominant cases had very high AD pathology. The brainstem predominant had very low and was just a single case. And the negative cases were, again, all over the place in terms of underlying pathology. And when we looked at these patients, the ones that were negative had very high Parkinson's scores, motor Parkinson scores. They had a history, actually, as we've gone into this a little bit more, they had a history of REM sleep disorder, but none of them had a sleep study, like I mentioned earlier, which has really shaded my feeling. You've got to do an insight sleep study to really know if somebody has REM sleep disorder. So that was really driving, I think, a lot of these individuals, their diagnosis of dementia with Lewy bodies. When we looked at the spinal fluid test for synuclein aggregate assay, all of the negative cases were negative. All of the limbic or neocortical cases were positive. But we had the ones of Alzheimer's and they only had amygdala were uncommonly positive. In the one brainstem case, some of the runs were positive, some were negative. So what I can say is if you have somebody who's positive, we had nobody who was positive that didn't have Lewy body disease. And if it's negative, there may be that it's restricted in anatomical distribution, but most of the time it's truly negative. So it's really good specificity and pretty good sensitivity. So what are our conclusions so far? Well, the mixed pathology is the rule in individuals with dementia with Lewy body clinical syndrome. Alzheimer's co-pathology is common, but can be mild. CSF ATN, the Alzheimer's marker analysis predicted whether people had coexistent higher stage AD pathology. So if we had a spinal fluid test that we used, amyloid tau measures, as well as the SAA test, really helped us kind of parcel out what's going on in people. The SAA CSF test for aggregated alpha-synuclein performed very well in this cohort. High positive predictive value, essentially 100%. A few cases when it was negative had very limited. The amygdala predominance really were kind of an Alzheimer's-like presentation, again, how Alzheimer's pathology. The one brainstem case, I think, clinically kind of presented as a REM sleep disorder case with some mild cognitive changes. In the true negative cases, at autopsy had no pathology, were truly negative. So these data can really help you in terms of trying to understand what's going on with a particular individual. So this kind of study requires a lot of collaborators. There are really a number across these different sites, and of course the NINDS and NIH that have helped support this. GE Healthcare has helped us fund the DAT scan imaging, Lewy Body Dementia Association, and some private funds have also helped with this study. So I think I'm gonna stop there. There's your evaluation that you can, and I'll leave that up and then see if anybody has any questions at all. Okay. I left us some time.
Thank you so much. If anyone has questions, please feel free to unmute. And if you cannot unmute for some reason, you could put it in the chat.
I'll maybe start us off while others are thinking. I'd love to hear your thoughts about how you're utilizing biomarkers right now and whether that's mostly within your research space, whether you're using that for diagnostic purposes or prognostication, just how you're placing that within space.
Yeah, I think that's good. That's important to know. Obviously, now that I'm at the VA and not at the Cleveland Clinic, the Cleveland Clinic, I tended to see people who didn't have a lot of co-pathology going on. They weren't on anticoagulants, things like that. Occasionally, I would talk to the cardiologist and say, they would say, "Oh no, it's not a problem if you take them off for a few days and you do a spinal tap for the test." But I do see, obviously you have some contraindications. We are trying to develop a blood test for synuclein pathology, but we're not there yet. We do use it obviously in our research cohorts. I do have families and patients who say, I really want to know what's going on, and so we will use it. Probably the one area where I get a little mildly agitated, maybe that would be a better lack of a term, is if you're going to do a high volume tap because you think somebody has hydrocephalus, and because you're wondering, is this hydrocephalus or just kind of asymmetric atrophy or something, please go ahead and do the AD biomarkers and do the SAA biomarker. You got the spinal fluid, you're going to take a lot off. Please send it out because sometimes it comes back. It's really helpful in terms of determining, if somebody comes back and their AD biomarkers and their synuclein biomarkers are negative, and they seem like they got some benefit from the tap, you might say, yeah, this person probably would be a good candidate for shunt. Versus it's good to talk to the family and say, well, we also saw that they've got Alzheimer's, they've got Lewy body disease going on. I think it's very common to see Lewy body disease because they have a gait disturbance that's not sort of classic, the Parkinsonism and so classic resting tremor. So it's really helpful to get it in that circumstance. But every family, I just run it by the families and patients and say, do you would this be helpful for you? Do you want this? And some families say, I really want to know what's going on. Some families say, if it doesn't change your management, I would say when a synuclein test is positive, I'm more likely to be careful, say with the antipsychotics. I'm definitely, I really like to get these people on a cholinesterase inhibitor. They really do well. It doesn't persist forever, but I've literally had patients, families come back and say, it's almost like he's back to normal. And in fact, when I have somebody that I think has Alzheimer's and I haven't done biomarkers yet, and the family comes back and says, it's really kind of weird. He's just doing so much better. I think, okay, this guy's probably got Lewy body disease, either with or without AD. And as I mentioned, I think I mentioned, actually, I'm not sure I'd specifically mentioned, the other thing that we see with the cholinesterase inhibitors in these patients is their hallucinations will go away, particularly when they're not so delusional about them. So the family will say, I'll ask them, oh yeah, it's weird, his hallucinations went away. So it's one of the other benefits. I tend to avoid memantine in these patients, just because if you look at some of the early data, it did show an increase in hallucinations in the treated group versus placebo. I see a lot of people who've on memantine and it hasn't had a problem, but I'll definitely, again, I lean strongly towards using the acetylcholinesterase inhibitors in these patients, either rivastigmine patch or donepezil, if they can tolerate it with bradycardia and all the other things we think about. I didn't really talk about antipsychotics. I would say when there's a delusional component to their hallucinations, so they're really acting on them, they're calling the police or whatever, because there are all these strangers in their house, things like that. Then I will add some antipsychotic. Kind of to promote sleep at the same time, I'll often start with a little quetiapine at bedtime. Oftentimes you can use very low doses, 12.5 milligrams, 25 to start with. And sometimes you have to add some during the day. If that doesn't work, I'll probably generally go straight to pimavanserin, which has a nice anti-delusional effect in these individuals that are more problematic. But I'd say most of my patients with DLB do very well with a cholinesterase inhibitor without any antipsychotic at all. Other questions or concerns or?
Oh, I had a question.
Yes.
I guess for us, more on the general side, of dementia care, I'd be curious to hear what you think are maybe some of the common, pitfalls that you might see that lead to, a wrong diagnosis of Lewy body, or, um, areas where, a generalist may not catch the diagnosis of Lewy body.
Yeah, it's a good question. I sort of mentioned in terms of incorrect diagnosis of dementia with Lewy bodies or Lewy body dementia often is in the context of people interpreting the delusions as visual hallucinations. So it's good to pin down exactly what it is that the family's reporting to you or the patient's reporting to you. Again, on the other side, making sure you ask the question, do you ever see things that other people don't see? And so that can be very valuable. So that's where I often see the incorrect diagnosis made. What was the second part of that question?
Maybe what you feel leads to a misdiagnosis of Lewy body.
Yeah. Well, again, I think the hallucinations tends to be the one where people misinterpret delusions. And of course, hallucinations in the context of delirium. I would say the issue there, though, is when I have a patient who has a history of MCI or dementia, and they have a delirium and it's pretty profound and they have hallucinations and so forth, it kind of raises my antenna to say, is this somebody with underlying Lewy body disease where it might have come out a year or two from now, but the delirium sort of brought it out? There is this literature that says Lewy body patients tend to have more delirium in the context of, say, a pneumonia or another effect, or UTI, something like that. So it's always good to keep that in the back of your mind. But I'm a little more skeptical in that context. If they're having hallucinations, that is this just a delirium in the context of a general dementia of some sort. There is a bit of a debate about how much Parkinsonism you'll see early on. I think some of us who come more from the dementia side feel like we see people who have almost no dementia or no Parkinsonism. Their DAT scan's normal, but develop that later in the context of what we thought initially was a executive, cognitive, maybe early AD type patient. But we still need to develop that data a little bit better. Just looking at the chat. Yes, we are still enrolling subjects. Part of the reason I go ahead and give these talks. And so in the context, as mentioned, I just moved from the Cleveland Clinic back to Seattle. And we just got our VA IRB approval for moving the grant here. Of course, it doesn't help that the government shut down, so we can't talk to our NIH colleagues right now, but we are moving it. And so if you have a patient you want to refer, we'd be happy to hear about that. And of course, we work with the Memory and Wellness Program over at the University of Washington and work a lot with those individuals. So definitely, if you have patients you'd like to refer, go ahead and reach out to me. I have a University of Washington email. I'm happy to take a look at those individuals. We'll just need permission to contact them. Thanks for asking. All right, well, I'll give you guys 5 minutes back. Let me know if you have any other questions, and thanks for the invitation to talk.
Yeah, thank you, Dr. Leverenz. Please, everyone, click on the link to fill out the evaluation or use the QR code. And yeah, thank you so much for taking the time today. I always take away new ideas that I can use in clinical practice. So thank you.
You're welcome. Take care.